Hello, everyone. My name is Dr. Richard Horowitz, and I am the co-host of the Dr. Talk Healing Lyme Summit 2.0. It's my great pleasure to introduce to you someone who you probably know in the Lyme community, a good friend of mine and colleague, Dr. Tom Moorcroft. We are going to be discussing today diagnostic and treatments for tick-borne co-infections, including Babesia and Bartonella, which are very important in the chronic disease population. So, Tom, I just saw you at ILAS just a couple of days ago. Thank you for joining us for this particular episode.
Yeah, Rich, thanks so much for having me. I mean, just it's an honor to be here, and it's also kind of a weird kind of experience, and so grateful to be doing it because I mean, if it weren't for you and all the early people in iLads, like I wouldn't be here personally and professionally. I wouldn't have been able to, after I got over the personal Lyme journey in Babesia, I wouldn't have been able to be here if it wasn't for your professional and guidance as well. So it's a it's just an amazing honor. So much gratitude. Thanks for having
No,
me.
of course, my pleasure, Tom. Tom, I'm sure people actually know quite a bit about you, but just tell them a little bit. You were sharing a little bit about your personal journey with tick-borne. You want to just let them know kind of how you, as a physician, kind of got involved in this whole thing?
Yeah, I mean, I think Rich, it came from in the past. The short version of the story is I got bit by a tick and multiple times throughout life. Never really had a problem until the one time that I didn't see the tick. So then I got a big rash, had a lot of brain fog and joint pain, almost got fired from my job, but mostly they knew I was a hard worker and they were just concerned that my productivity went down. And my boss one day found me staring at a computer screen and drooling over myself when I was working at the Institute of Ecosystem Studies, where like Rick Ostfeld and a lot of the people in your neck of the woods are. Now called the Carey Institute. Unfortunately, like 3/4 of the people who worked there had Lyme, and no one seemed to know who Richard Horowitz was, even though he's 20 minutes down the road at best at the time. But I got treated for 10 days. I was sick for the next 8 years until some of the other early people in iLads, I happened to rotate through their office, and I was feeling so bad. I was like brain fog and fatigue and joint pain. And like everybody, I went to all the doctors, and it was before I knew all the things that we're talking about in this amazing summit. And I was just trying to follow their instructions, and everything was, it didn't work. Oh, most people respond well to this medicine, but you're responding differently, you know? And it was every time I went to the doctor, it was an excuse of why it didn't work. And it was really, I felt kind of really, like my experience of who I was not valid. They were trying to tell me it was all in my head. And then I met these amazing doctors where they were seeing other people like me. And for the first time in almost a decade, I was like, holy cow, like there are other people like me. And so I felt like I had a community and I wasn't just out in the cold by myself, but I also felt hope. And so ultimately it was a combination of doing personal practices where I changed my lifestyle, my diet, and really sorted to brought my energy back into my midline, so to speak, with some yoga and some other meditation. But then I needed to get a proper diagnosis. And so I got diagnosed with Lyme and Babesia. They worked with me. I got dramatically better. I always like to tell people at the time we're talking, it's about 12 and a half years with zero symptoms. So it can be done. I know that you're on the forefront of changing that for people. And then ultimately, I just went off in the practice to try to just help and serve people. And one day somebody stumbled in. I was like, damn, you have Lyme. And then I was like, I helped her. 2 months later, she referred a friend to hers from high school. This gal was in a wheelchair. It took 2 or 3 months. We got her out of a wheelchair, and I've never been able to look back. And I remember one day you said to me, do you really want to do this? Because it's going to take over take over your life. And it certainly has. And it's been such a blessing. And I mean, I think it's through personal experience and also just seeing other people suffering and the goal to alleviate their suffering that I've gone down this road.
Yeah, no, it's a great point. And look, and the thing is we are blessed in a sense. These are very challenging patients, but because you and I have been on the front lines for so long, we've been able to figure out effective diagnostic and treatment protocols. And what we're going to discuss today, and you just brought it up, you had an experience of babesiosis, right? I was the first doctor in Dutchess County where we're living to actually diagnose and
Yeah.
treat babesia. It was actually a similar story. I had a young woman in a wheelchair for 5 years, could not walk. She had chronic Lyme, was being treated by one of the Lyme giants at the time. But she came into me in her early 30s with drenching night sweats. And, I went
Yeah.
through the differential diagnosis like you're supposed to do as a board certified internist. It wasn't hyperthyroidism. She'd not been out of the country with malaria. She didn't have non-Hodgkin's lymphoma or TB. She didn't have drenching sweats with a cough or mediastinal lymph nodes. She didn't have brucella, Q fever. Like we ruled out all the things. She obviously wasn't in menopause in her 30s. And it turned out that, in fact, we sent the ticks from Rick Osfeld's lab, when Rick and I connected for the first time through Jill, one of our fellow camaraderies. And we sent them out to Hygienics and other labs, and we showed that there was Babesia in the ticks. We showed the health department and the insurance companies over 100 cases of PCR positive in the blood for Babesia microti with antibodies with FISH testing. They still told me Babesia does not exist in Dutchess County, New York. You're making this up, and I guess all my patients were too, who are getting better. I'm a great placebo master where I convince people they're well, but ultimately, this woman who was in a wheelchair, we gave her 10 days of Mepron, atovaquone, and azithromycin when it worked, right? When the drugs worked. We're going to talk today about why it doesn't work. And she walked out of the wheelchair in the next several months and has been skiing, right? I know you're a big skier, and she's been great ever since. So let's talk a little bit about, we're going to focus today on the co-infections, on Babesia, Bartonella, and maybe some of the other co-infections that, are affecting Lyme patients. I know you see it and I see it. The major ones we learned about years ago was Babesia microti. Duncani came along years afterwards. We published a study back several years ago that we were finding it not just in the Pacific Northwest, but in other areas of the US. And there's still controversies on this, by the way, because we heard from Galaxy right over the weekend when we were at the LILEDS conference that some people are not finding Duncani, but Igenics is finding it right on their Babesia immunoblot all the time. And now the new kid on the block is Babesia oticolii, right? So let's talk about, why don't you tell me a little bit about your experience, diagnostic testing. Let's start off with diagnostic testing and why people need to look for Babesia, why it's so important.
Yeah, I mean, I think what was really interesting in my personal experience, I kind of skipped over quickly. When they gave me the doxycycline, the guy said, hey, you'll be good to go with 10 days, right? But the first 4 days, it was July. I was 23. I was laying in my parents' basement where it was a little cooler than July usually is in Jersey at the time. And I was having alternating shakes and chills, alternating with sweats. So I mean, I wasn't a menopausal or menopausal man at 23.
Oh, you've got my joke. You got that joke after a while. You're not in menopause. Yes.
That's right. I agree with you because but it's like, I always say, like, it's funny when I go over the questionnaires, I see about 50% children. And when I have a 4-year-old boy who's in menopause or a 6-year-old girl who's in menopause, it's, you got to look at babesiosis, And so one of the things that I found is, like, I always learn from you and like Charles Ray Jones, who was so influential on so many of us, including myself, is that if you're not getting better, you have to look for a co-infection. There's a reason that Lyme's not as easy to treat as we like. And some of it's the Lyme itself, and some of it's that there's co-infection. And I think that over the years, I think we've all learned that co-infection is the rule, not the exception. So it's one of these things where when you have people, and going back to my story, right? Everybody I went to is like, you kind of look like depression. You kind of look like bipolar depression. You kind of look like fibromyalgia, but it's all not quite. And it's like when I see the not quites and it doesn't make sense, like the kid with acute OCD and rage out of the blue, and a kid who's normally been chill, then I'm starting to think that there's been another infection that might have triggered something. And to your point, the reason we have to test for these things is they're way more common than we thought. If we go back over the years, I mean, there's like 20,000 people with Lyme every year. Then it's 36. Oh, now it's 300 and something. Now it's 476,000. Oh, by the way, the 476,000 may be a 7-fold, understatement of what it really, and we're probably looking at 500,000 people a year getting Lyme. And like, if you take Connecticut, any given year, there's like 55 to 90% of the ticks have Lyme disease or a strain of Lyme. But then you've got at least 8% of them, 10% of them every single year that have Babesia. So if you're getting bit by a tick, you're exposed. And even if you don't see the tick bite, the biggest thing, as you know so well, most people are getting it from the no-see-um nymph tick, the size of a poppy seed. So the exposure on the East Coast in particular, but now with global climate change across the country and the globe, everybody's having an opportunity to be exposed. I've had colleagues call me, they had somebody bit in Oklahoma where there's no Lyme. They got bit by a deer tick, got the EM rash, got the positive blood work, had a positive response to treatment. And they said it wasn't there, but they had the tick and they tested it and it had Lyme and Babesia in it. And you're like, oh, it must have come from a songbird. I'm like, well, yeah, but it's still there. So we're all getting the exposure risk. And part of the problem that I've seen too is I remember almost like a Venn diagram. It's like, we used to try to say symptom recognition. This is always Lyme. This is always Babesia. This is always BART. But I think as we've gotten more and more toxicity in the environment, both physical toxicity as well as emotional toxicity, that the overlap, the blur has become bigger. And so a lot of our presentations are people who don't really fit one or the other, and they kind of look like multiple different things or a brand new thing. And then you're like, well, I'm a good clinician, but I also need some tests to help me sort through the different pieces so I don't miss it. And even one of the cases I presented at ILADS where, I did the IGeneX immunoblot testing on him. Everybody had looked at Lyme and Bartonella, found it. They were treating it up the yin yang. And this actually, I have this one guy that I was talking about, and then I have a family of 4. Same thing. Everybody's treating the Lyme and the BART, and they never really looked at Babesia. And so then I did, and because they had one time checked a fish test through, another lab, and it was negative, they just blew it off. And I'm like, well, sometimes we need to look with the serology. And I learned this from you in the beginning. Sometimes you got to do direct, look at some DNA PCR. We got to look at an RNA fish test and the serology, the antibody test most people are looking for. And I found the antibodies were positive in all these people who had been treated for 2-3 years by really, really skilled clinicians. And it was then when I found the Babesia and treated it, which from their symptoms, it looked more Lyme, Bartonella forward, but there were still those hints. And the testing helped us make that decision. And then it just changes everything. So I think the thing is, they're all there. And the likelihood of you getting, if you've got one, to have more than one is high. So utilize your optimal testing as well as your differential diagnosis.
Right. So when we talk to people, I mean, I always mention it's kind of like people in general. Obviously, you can't say across the board, but it's for the most part, people are getting the 3 Bs. They're getting Borrelia, Lyme disease, Babesia, and Bartonella. Those 3 Bs are showing up in the vast majority of patients. So the way we initially diagnose it clinically, and you started talking about the sweats, is in the validated Lyme symptom questionnaire that we validated with the State University of New Paltz researchers back in 2017 and 1,600 people. On that questionnaire, which for those of you listening, you can just download it from our website, www.cangetbetter.com. Just go under symptoms. You'll find the questionnaire, download it. Yep. Questions 1 and 22. Question 1 is day sweats, night sweats, fevers, chills. They can be shaking chills like Tom was describing, flushing also you'll see. And question 22 is an unexplained cough or air hunger. There's shortness of breath that's not related to asthma. It's not related to emphysema, and people can't explain it. Those are the classic symptoms. And then as Tom was discussing with me, you'll also see these overlaps with fatigue and headaches and joint pain and even neurocognitive issues with brain fog and mood swings. But it's usually the malarial symptoms that give people at least a clue that it's there. But the problem with the serology, and you're right, I mean, I do get positive serologies, but the problem with the serology, and we usually talk about doing multiple tests like you just did, we will do serology. We may do PCRs. Actually, I do serology and fish testing most often because in the Lyme population who have Bartonella, a lot of these people are immunodeficient. So they're lacking immunoglobulins in subclasses. They don't make antibodies well. If they do make antibodies, a lot of time they're IgM, not IgG, because the B cells have been knocked out to make long-term antibodies. You see it in Lyme and in Bartonella. And if you're on IVIG, you're doing, immunoglobulin therapy, you can't rely on the antibodies because it's a pooled serum. So then you have to rely on direct testing, which is either PCR or fish. And we're finding between IGeneX, their, Babesia fish test, or occasionally T-Labs, which does their 18S, but also the Babesia otocolii, right? We're seeing those fish testing be positive. So, Tom, I think you're doing the same thing. You're doing kind of a panel approach where using antibodies, sometimes PCR and fish testing to find them and using the questionnaire for symptoms. Is that we're doing pretty much the same?
Yeah, I think so. It is. It's about the symptom recognition, knowing there is an overlap. I mean, other things that I notice a lot of are kind of the bone pain and the rib pain, perhaps because of, Babesia likes to live in red blood cells and that kind of that head pressure. But yeah, everything you're saying is like, you got to look for those key symptoms. But then it's funny that whenever I talk about this, I almost forget to mention, I have a hypogammaglobulinemia or CVID. And I found out I diagnosed myself, and then I figured it out my dad, and I was like, oh crap, that's why dad's got his issues. Turns out my mom also gave it to me. So both my parents have CVID. What are the chances, right? But thankfully, my brothers and my daughter don't have it, which is great. Thanks to my wife, Jill, for bringing the good genes in the immune system function. But yeah, the labs work different in people who have hypogam. And just in general, whether you have it congenitally or acquired through all these infections, like you're saying, it's really important. So we do look across the board, and sometimes I do it all at the same time. Sometimes I'll stagger it. A lot of other people, and I know you're doing this, is like, we're looking at heavy metal toxicity. We're looking at mold toxicity, because to me, it's really that chronic toxin overload. It's like, I'm a vessel, I can hold this much and I'm okay. But as soon as I overflow, it's a mess, and really, I think that's where you look at the MSIDS model and stuff. And it's a great way to help us make sure that I've always said number one is like all of internal medicine and Harrison's, and the rest of it is the stuff that actually keeps our patients sick. So I really think people should dive into your model and look at a way to all of it, but specifically for tick-borne stuff. Sometimes, and the other thing I always found interesting about Lyme in particular, and I know it overlaps with the other infections, is over time in an untreated or a treated individual, their antibodies will fluctuate. And if you look at like Monica Ember's, I think it was 2017 study, or second really big one that kind of like hit the world by storm, at least the Lyme world, is showing that every individual has if you measure different antibodies to Borrelia, they have a different response to each one. So there's individuality and inter-individual individualities, meaning just like everybody, it's like it's all bets are off, because every single different antibody a particular person will respond differently to, and then you and I would respond differently across the board. So this is a really challenging place to be. And I really agree with, you got to look at the different testing and make sure you're getting it, figuring out what those symptoms are, figuring out what they have, so that then we can actually adequately treat them.
Yeah. And regarding the testing, I mean, for patients that say I can't afford, IGeneX or T-Labs or any of the other ones initially, I'll do a Babesia microti and a Babesia duncani locally through Quest or LabCorp. And there can be cross-reactivity with duncani with some of these species. It's just what I think gets confusing for doctors after a while is, they learned in medical school you need a fourfold increase in titers. We see many people that are IgM Babesia low level, showing exposure. The immune system doesn't get that big hit. And I think it confuses doctors a bit. And also, they learn in the textbook presentations of Babesia, you should have hemolytic anemia where the red blood cells burst apart and you get kidney failure and the liver functions go up. And I've seen 2 cases of that in the last, 40 years of clinical practice and 13,000 people. I don't see any of the textbook. Yeah, you don't see it either, right? In these Babesia cases.
No, it's interesting. I'll see a little lower, like a general, like guys should have a higher hemoglobin or, red cells than women in general. But I'll see guys who drift down and they look more like what a menstruating female might present with. But for the most part, I've only seen that in acute, like, a guy who his hemoglobin went from 16 down to 10 in a week because he got Lyme, Borrelia miyamotoi, Babesia, Bartonella, and Anaplasma from a single tick bite, and we have it all confirmed with DNA and antibody. I don't even know how the guy made an antibody response, but he was nearly hospitalized. But the beauty of his case is, like, it only happens, and you had the low white count from either the Anaplasma or the Borrelia miyamotoi. You had the low he had anemia from the Babesia, presumably, and then all of those can hit out platelets. Everything drops. So he got a huge load. That's so uncommon. Most people are kind of that subclinical, subacute presentation. It kind of creeps in over time. And I think this is what we're all looking for, why the doctors are so confused. We're taught the 1 out of 1,000 presentation, the acute Babesia that is really, really bad, really life-threatening potentially. Whereas most of our people just get enough Babesia to allow the Babesia to get a hold in your body and start to cause small trouble that you don't really notice for 3 or 4 weeks, or maybe 3 or 4 or 5 months, and sometimes longer. So I think that's really the challenge. We're taught that it's almost like typical chest pain when I got into medicine. Everybody's saying, oh, typical chest pain. And then women have atypical chest pain. And then they researched atypical chest pain, and they found out that the atypical presentation was the most common presentation in men and women. So we originally thought it was this finite thing. And we've learned that it's not. And I really think that that's what you were alluding to, is the presentation is not the textbook presentation.
Right. And again, for those listening, Tom is just bringing up some important points. We're discussing today mainly Babesia bartonella, but also other tick-borne co-infections. And what Tom was just discussing with you was that in patients that get an acute tick bite, if you get a low white cell count, leukopenia, low platelet count, thrombocytopenia, or elevated liver functions, transaminitis, either one, two, or all three, if you get that early on before the antibodies form for Ehrlichia, Anaplasma, Rocky Mountain spotted fever, Q fever, typhus, Borrelia miyamotoi, heartland virus, bourbon virus, all of these things I just mentioned can cause these same initial symptoms. So that means you've got to get people on doxycycline immediately, including kids and pregnant women. This comes directly from the CDC because
Yep.
you can die if you don't get in doxycycline early. Some doctors have waited for the antibodies to form, and at that point, it's too late. Rocky Mountain spotted fever, you don't always get the rash on the hands or the feet. So what you were discussing with clinical symptoms and lab testing is actually very important. And in Babesia, you can get it from a tick bite. You also get it from blood transfusions. A mother can transmit it from the mother to the fetus. You can get it from solid organ transplantation. And recently with Bartonella, they just showed also that solid organ transplantation, apart from fetal transplantation, blood
Yeah.
transfusions, it can happen through a waterlase that you get this. It's not always right through a tick bite.
Well, and I think Bartonella, you really bring up a really great point. Right before the pandemic hit, I was actually talking with some people. We got to get back on this. I have a group of patients from New York City who basically don't have pets. They're not like going out into the woods or anything. They pretty much are city dwellers and in apartments and stuff. And they're all of them have this really high likelihood, like 75% of this population, and especially in Brooklyn and the Bronx and stuff, were coming in with Bartonella henselae. Like it was just like so much more than I was expecting. But also without evidence of Lyme or tick exposure. And then I started diving in the literature. You've got Bartonella can be transmitted from, house spiders, and a lot of people know about cat scratches and cat bites and and then fleas and fly and sand lice or sand flies and all this. But then the other thing that, especially when pans and pandas with Bartonella can mimic it, Bartonella can trigger it in children, this sort of the acute neuropsychiatric presentations associated with a lot of these things. Bartonella can be transmitted by lice. So I've seen like lice go through a classroom. And then I get a couple of patients. One's got acute onset ADHD in a previously really focused kid. The other kid has acute anxiety or rage. The other kid has acute OCD. And it was teachers, when I talked to them about this in school systems, their minds are blown because people are saying, always trying to think about, hey, is Bartonella transmitted by a tick? Well, we don't see Bartonella in the Northeast and ticks all that commonly, but if you're down in North Carolina or in other parts of the country, you do. If you're in the Netherlands, even as back as far as the 90s, we know that like 70% of the ticks have Bartonella species, and only about 56% of those ticks had Borrelia. So there's a lot of exposure risk. And I think, without diving into like different rabbit holes for each one of these, we know that it's complex. And the exposure risk can not only be, at least for Bartonella, it can be a lot more than Lyme and Babesia. And then with Babesia, it's funny, you talked about Babesia duncani. All I know is I don't know what it is, because some people, they've done ticks in the Northeast, especially in Connecticut and New York, from Tokar's work, when they do the DNA of the Ixodes scapularis tick, we've got Babesia microti and Babesia odocoilii. And, a year ago, I was saying there's only 2 cases of DNA proven Babesia odocoilii in people. And then like every 2 minutes, we have another DNA sequence of somebody with odocoilii. So I don't know. But I've talked to other people like at IGeneX, they're like, we don't see odocoilii in human samples, but other people do. And then researchers at Yale are like, every tick we look at doesn't have it. Or doesn't have duncani. But all I know is that there's microti and then there's other. And the other is sometimes harder to treat. So like when I do Quest, a lot of times I get a 1 to 256 Babesia duncani antibody IgG, or they call it WA1. I mean, that I think is probably something else. And I've long noted, even before we had the research over the last 4 or 5 years, into what herbals, botanicals will work. And then this year, how tafenoquine works. I've seen it's hard to treat. And so I've just been treating it like really hard to treat Babesia, irregardless of what the name is, because what I know is I published in 2014 on the first cases of Borrelia miyamotoi, and I think you published one or two at the same time. And and it was funny because the other person on my paper was Catherine Lantzman, who I know had done a lot of training with you as well. So it's like the three of us are saying, hey, look, this is a real human infection in the United States, and those were in the first 73 cases known in the world. But when you look back, we've known Borrelia miyamotoi is in the same damn tick that gives you Lyme disease for 30 plus years. And then when they went back and they look at the stored samples, all the people had like a 41 band positive and not anymore. Well, it turns out that most of them who had wishy-washy Western blots for Lyme and it's all in your head disease actually turned out to have Borrelia miyamotoi.
Right.
So we know if they're in the tick, we can get them. And so we should be looking for them. We should be treating them clinically.
No, it's a very good point. And just to finish up a little bit on Babesia before we move on to Bart, because these are really the two big ones that are keeping people ill. You had just presented a great presentation at iLads on tafenoquine. Now, years ago, the treatments for Babesia was clindamycin and quinine. I used to joke with people that if they didn't behave themselves, I would give them this treatment because, it's a horrible treat. It would give you ringing in the ears like an alarm clock was next to your head for 24 hours a day. There'd be nausea, there'd be vomiting, there'd be rashes. You can get QT prolongation very difficult to tolerate. So most people went to Mepron, atovaquone, and zithromycin. It worked for many years. And then all of a sudden, it didn't. And back in 2016, there was an article published that there's genetic resistance now, right, to Babesia microti. Regarding Duncani, the article that was published by Sunya Schweig and John Hopkins researchers is, well, if we add a little bit of Japanese knotweed and Chinese skullcap and artemisinin and acornia and cryptolepis, right, these 5 herbs, we can get some good help. And it helps, but still not enough with these other species like you're talking about. And this is where now tafenoquine and atovaquone, or tafenoquine and malarone, right, with or without zithromax, so just briefly, because I want to make sure we have time to discuss Bart, I've generally been seeing good results with tafenoquine, 600 milligram loading dose. This is what I'm doing over 3 days with a 300 milligram dose per week instead of 200 because I've had some resistant cases. Is that roughly the protocol you're using? I know for you're using some tweaks with it. Tell people a little bit about your success with this new protocol.
Yeah, I mean, I love it. And, many thanks to Chikri Ben Mamoon's lab at Yale for actually doing the work, because it's one of the few things we see in Lyme tick-borne illness where we actually have a in vivo or in a primate or a mouse, in this case, model to really guide us. Because a lot of the work is just done in Petri dishes and we don't know how it works in a human or in another mammal. And the beauty of tafenoquine is, we can do loading doses of 600 milligrams, 200 milligrams a day for 3 days, and then 200 or 300 milligrams a week. And I'm finding that like a lot of people do really well with the standard protocol. Some people do, like you said, need that extra 300 milligrams. Definitely. I typically am combining it with liposomal cryptolepis, and a combination of some artemisinin, liposomal cryptolepis, and liposomal Japanese knotweed, but then adding all those other herbs you mentioned in as tinctures. And then based upon what else they have, I'll layer in like the atovaquone or the rifampin. And I've even been done people with dapsone and tafenoquine, which I think is a more advanced protocol. It's definitely not the easiest thing to do. But the thing I love about it, and especially since about half my practice is children, it's not, tafenoquine is FDA approved for malaria prophylaxis and radical cure of Vivax and Ovale in certain forms of malaria. But only 16 and up. So below that, we are using it kind of off-label for that. And anybody using it for Babesia at the moment is technically off-label. But the Australian Therapeutic Goods organization, which is kind of like our FDA, has studied it down to children as young as 2 years of age and found safety. And they've even in extreme cases done it in children as small as 5 kilograms, which is only 12 pounds when it was life-threatening, and they found it to be safe. So the beauty is I've used it in younger children, and I can load them at a weight. So some kids need lower doses because they're smaller bodies, but the once a week dosing it really helps across the board in children and adults, that we can change the dose, and we can get really therapeutic levels only once a week. So compliance is really big, especially for our children and for our really sensitive adults or sensitive kids. I've even, I had a few people start to split the tablet. No one knew if we could do that or not, but I contacted the companies that make tafenoquine. There's some, 60 Degrees Pharma and GlaxoSmithKline. And as far as they know, that's safe as well. And clinically, it's been safe. So we have a lot of flexibility. We can go higher. I always warn people, we don't need to go like super duper high because the pharmacokinetics, basically, if I take more, I get more in my blood. So your 300 milligrams is a really well-studied dose. And it's high enough. What's interesting is if you do 100 milligrams a week in most adults, you're going to get to what Dr. Ben Mamoun's lab studied for radical cure of Babesia microti and Babesia duncani, which is great without relapse. When they removed it and let the mice continue to live, they were fine. And they also developed sterile immunity to it. But the beauty is, we know that they were doing half of that dose, so 100 milligrams, essentially a 300 milligram load with 100 milligrams a week. And then they added atovaquone at kind of our standard doses. So if we need to, because that was an acute Babesia study, we don't have chronic ones yet. That's being worked on, as you know. But we know we can do 200 milligrams safely because they've studied that in humans, and 300 milligrams. But we know those doses are double and triple what we need for cure, at least in a mouse model. So we know that we're in a good place, I think.
Well,
And I think
you've used it effectively, and so have I. And the thing for people to know is, it was really only in January of this year they really started publishing.
right,
With Louis Marco had published on, who I work with at the New York State Department of Health Tick-Borne Working Group. They've been publishing with Worms's group also that for these people that are immunosuppressed, that had failed classic
right,
treatments, that tafenoquine basically is helping. And ultimately, a lot of our patients are immunosuppressed because they have chronic variable deficiency. Some have had long COVID. They have T cell exhaustion, where the natural killer cells and T cells are working.
yep,
And we are definitely seeing better results with the fish testing. I had one guy that was fish positive, by the way, 5 times in a row, did tafenoquine and finally ended up clearing it.
wow,
So, I mean, we are seeing finally some success with it. I think the final stages that we need, because you're right, I mean, nothing approved yet for chronic babesia, but there are no effective treatments at this point, except ultimately
right.
tafenoquine, right? I need to just see eventually, I'd like to see some studies of comparing tafenoquine alone, tafenoquine with Malarone, tafenoquine with atovaquone, tafenoquine,
100%.
atovaquone and azithromycin in the resistant patients without herbs. If I could,
Well,
design a study, that would be the ideal study I would like.
I would love somebody to give you like $25 million to do the dapsone studies and the tafenoquine, because it's like we need to do like so many more studies. And one point I really like to make too, because you pointed out something so important. 10 years ago, we were kind of okay with Babesia microti. And if you have a lower virulence Babesia microti, even in the tafenoquine studies, you could do just tafenoquine. But if it was more virulent or a higher load of microti or duncani period across the board, we needed atovaquone, and we probably need other things. But what we've seen in some of the newer studies that are looking at the need clinically, and this is coming out of the IDSA, Infectious Disease Society of America membership, what they're doing in regular hospital-based infectious disease clinics is Babesia microti resistance to azithromycin, clindamycin, and atovaquone for different reasons. And so what you're seeing and I'm seeing and all the other docs are seeing clinically and the patients are experiencing, we're finding the science that backs that up. And I 100% agree. That's what you need to do. We need to do these studies where I would love to see all those combined with dapsone. I would love to see the herbs studied with the meds in a mammal model. We need this, and it's coming. But I just think it's important to know that what we've seen clinically, the research is catching up, because I feel like our patients run out of hope sometimes and they're like, we just didn't have the science to back up what you're experiencing. And ultimately 5 or 10 or 20 years later, we get it. And in my career, I feel like in the beginning, it was like 20 years later. And then I said, oh, it's like 15 or 10 years after the science catches up. Now the science is catching up in 3 or 4 years. So we're picking up some pace and there is some hope, but I mean, we're really finding science that supports what we're seeing clinically and what patients are experiencing. And that gives me a lot of hope for maybe we are on that precipice of making this not such a complicated thing.
Right. And so again, and of course, Tom, you brought up a great point is people need hope. And you should know now with Babesia, we are seeing definitely better success with the difenacoin protocols for some of these people. Because in the dapsone protocol that I've developed, we found that if you had active Bartonella, which we'll get to in just a second, a lot of those people who did double dose dapsone, it did not keep them in remission. They needed higher dose dapsone pulsing, and Babesia interfered in 50% of the cases where dapsone sometimes helps with Babesia. It does knock it out in some, but it's maybe a quarter of the patients, not the majority.
Right.
But the difenacoin's turning out to actually be a good drug. The only thing I'll mention for those using it who are listening, for doctors and patients, the two major side effects you have to watch for is hemolytic anemia. You can get a little bit of a drop in red cell counts. Nothing like dapsone, up to 2 grams is what I've seen. And the
Yep.
methemoglobinemia, where you don't carry oxygen well in the blood, 6, 7, 8%. I will use some low dose methylene blue when I'm doing this protocol in patients generally. Glutathione lowers methemoglobin levels, so does vitamin C, vitamin E, cimetidine, 400 twice a day is a trick I learned for the dapsone. Even INADA, NADH, because NADH reductase is an enzyme that gets rid of methemoglobin. So generally well tolerated, better than Lariam, mefloquine, the cousin of tefenaquine is mefloquine. I probably used it in 1,000 patients easily years ago. I haven't seen the same neuropsychiatric side effects. You have to look for it,
Yeah.
but I had not seen it in tefenaquine. But you do have to watch for slight hemolytic anemia and methemoglobin. So, right, those are the big things you just have to prepare for when you're
Yeah.
using this medication.
And I see a fair number of people, especially when we start getting increase in fatigue and brain fog, which is like I mean, the most non-specific thing ever. But it also has some fungal properties, anti-yeast properties. So some of our people have candida overgrowth or mycotoxin patients may want to know that they have that. But most people are clearing up pretty quick. And I would agree, like, I love the low dose methylene blue with this protocol. Obviously, you're using a lot more when you're on a dapsone protocol, but it's mostly well tolerated. And the 12-month study of healthy volunteers, which again, different group of people, but they dose people with a 600 milligram loading dose and then 200 milligrams a week for over a year. They did see some people bumped up their methemoglobin, but almost everybody, in fact, I think everybody in that study, if you just wait a couple weeks, it comes back down on its own. And I've certainly seen people stabilize. Now, our population is a little different. They're on more meds, they're sick. So you gotta manage it a little bit more, but it's a fairly well-tolerated therapy compared to many of the other things that we have to use to get people over the hump.
Yeah, good point. So let's turn to the next half of this and now discuss Bartonella, which is the other bee that seems to be really causing havoc, right, in a lot of our patients. So
For
the
sure.
problem with Bartonella is, right, first of all, there's only one study in ticks, Ixodes ricinus ticks in Europe. They showed a specific species of Bartonella bertolesi, that it was transmitted. But as you said, it can be spider bites, mites, red ants, fleas, lice. There's so many different species of Bartonella. There's over 18 pathogenic species. And that's why if you just do a Bartonella henselae or Bartonella quintana or Bartonella bacilliformis from Questral LabCorp, you're going to miss the
Right.
species like Vinsoni, Elizabethae, right? Some of the species we're seeing commonly show up in our patients. The problem with BART is it looks like Lyme, it smells like Lyme, but there's a couple of distinguishing features, right? Neuropsychiatric symptoms, usually way worse. You were discussing Bartonella rage and OCD and ADD. The neuropsych symptoms is worse. We see the chronic variable immune deficiency. When people have multiple Bartonella species, we just published this last year, we found that the CVID, the immune deficiency, was worse. The neuropathy was worse. These are the people that failed gabapentin, Neurontin, and Lyrica, and Elavil, and duloxetine. They were on all these neuro drugs to try and keep down the neuropathy. Horrible neuropathy. The worst autonomic neuropathy with POTS. They were passing out more.
Oh,
So those are the tricks. Pain in the bottom of the feet, very severe, right? You get the Bartonella striae, very classic striae. They're like either reddish perpendicular to the skin planes or whitish, sometimes in a Christmas tree pattern. And Bartonella granulomas we'll see on the hands and feet. But ultimately, it's bad fatigue and horrible brain fog and baroneuropsych and bad joint pain, right? It's very tricky because it overlaps. And that's pretty much what you're seeing also, Tom. And it's interfering with the dapsone protocol where we're needing these quad dapsone 6 day pulses, at least 4 of them, every 2 months to
Right.
be able to really knock down the load of the Bartonella.
Well, it's like I talk to people a lot about this because I'm like, how do and I know we both train practitioners to help make it easier for other people. And in our training program and just in general, I'm like, look, think about who all the players could be based upon your clinical. And even if you have a negative lab test or you're waiting, when you're creating a treatment, and like this is what I love about the DAPSone protocol and just even like the way I was trained, like with Ray with kids is to build protocols. If you're looking at Lyme and strep, well, but you can treat Lyme with things that'll really only treat Lyme and maybe strep. But if you're thinking maybe Bartonella and or Babesia, I can start coming into my intracellular drugs. I can look at my azithromycin. I can start to think about where I might bring in, like if there might be a rickettsial infection like an anaplasma or something like that, Rocky Mountain spotted fever, I might bring in minocycline or doxy. But it's like I can build protocols where I have 2 or 3 intracellular drugs, which would be our classic way of looking at Bartonella, because I mean, in test tubes, at least within 12 to 13 hours, we'll see 2 generations of Bartonella and resistance to macrolides like azithromycin or clindamycin, or excuse me, clarithromycin. So we need to be planning ahead. But when I plan to add more, I'm like, how can I, especially seeing children taught me this, is how can I narrow down my protocol as best as possible, what cover the most. And Bartonella, I'm always thinking about it. And I mean, unless somebody's got an EM rash from yesterday or maybe a week or 2 ago, and they just have like early signs. I mean, it's so ubiquitous. I am always looking to build out my protocol, planning that Bart might be there, Babesia might be there, so that like I'm not caught with my tail between my legs. And what I love about the botanicals too, especially Cryptolepis and Chinese skullcap, and Artemisinin and Alcornia to some degree, is that those 2 in particular cover all 3 of the big Bs. Now, if we add in the knotweed and the black walnut hull, and we add in the Alcorn, and all the other things you mentioned, cat's claw, we're going to hit Lyme and Bartonella really strongly. And cat's claw is a great anti-inflammatory and immune modulator. But if I'm thinking that, I can say like, hey, I might be starting you on say azithromycin and minocycline while I'm, clinically while I'm figuring things out. I'm going to layer in those herbs or even if I just started with one drug, for whatever reason, which I don't think you and I usually do, but if you had to, right. But I'm just saying if you're new and you're nervous and you know they have Lyme, but you're thinking they have the others, layer on those herbs that'll cover all of them. So like if I was on azithromycin, or minocycline by itself, and they happen to have Bartonella, maybe it's not the best coverage by just adding the herbs, but I've given myself a bit of a safety blanket. And I really try to teach like Dapsone for somebody who's new to this in the last like 6 months and they just took your course, going to be a little scary to start. So if you want to start somewhere, add the botanicals and combine them as if they're your second or third intracellular, and then get your confidence up and layer these things in. But just clinically, it's a great way to build a protocol for someone who's trying to develop confidence. And, a quick side note, Rich, on Dapsone, like I remember the beginning where we were using a little bit. And it worked for some people. I've had people where they 50 milligrams twice a day with doxy, 100 milligrams or 200 milligrams twice a day. 6 months later, I don't have a patient anymore because he's cured. I'm like, very unusual for a chronic Lyme person to be that quick. But as we go through all these protocols, it's like we have steps that we can do. We don't all have to go to like quad post Dapsone our first time out. And a lot of people need that, but I think that a lot of the doctors I love, and I know this is what you did for me, is you empowered me to learn how to think about it, and then we can layer these things in. And I think it's a very exciting time as a former patient. And my daughter actually had Bartonella from her cat because we had cats before we knew about Bartonella. And then, and now we can't stop having them because she loves them, but they're indoor only now. And the other thing is like she had Babesia duncani in the East Coast after a school trip, and that we were able to get DNA and antibodies positivity. But what was so beautiful about it was I knew what to do right away, and I got to treat her really well in the acute phase so that it was less likely to have long-term stuff, and she's not had any long-term issues. but it was like I combined everything. And I think that that's really the thing. And when you get into the Bartonella world and you get comfortable with treating Bartonella, I feel like you need double, triple intracellulars. You need to add in your methylene blue. You need to add in your botanicals. And I find that like the study out of Hopkins where we looked at azithromycin and methylene blue, or rifampin and methylene blue being really good, is great. I would love for them to take the next step, because when they put zith and rifampin together, which is one of our classic combinations, it didn't work as well. So I'm like, we need to figure out if we put the three together, if it does. Because one of the things that I find that really interesting about methylene blue, aside from all the wonderful stuff you highlighted a minute ago, there's even at lower doses, but it tends to be across the board. It helps extinguish in this concept called fear extinction. And so a lot of times our patients are so gaslit, medically traumatized, or they just wake up every day feeling like crap. And when they start to feel better, they're waiting, for the ball to drop, so to speak. They're waiting for the ticking time bomb to explode and then the flare again. But methylene blue has been shown to, like, in fear extinction, which is really defined as this decline in the conditioned fear response when it's no longer reinforced. The problem is if you wake up every day and you feel like crap, you're gonna go, oh, every day I'm gonna feel like crap, and I'm afraid of waking up feeling like crap. But when you have a week or 2 weeks or even 4 months after maybe you've done your 4 quad dose dapsone pulses, and you're like, oh my God, like I'm actually getting better, but I'm waiting to get worse again. And so methylene blue and that might be some of the power, a small piece of the power of your protocol, because now we can help the mind unwind and unlock, because a lot of it's positive feedback loops in the mind. If the mind is saying, hey, the nervous system says, the more fearful I am, the easier it is to be fearful, the more fear I have. And then every day I wake up in fear. And then you treat the Lyme, Babesia, and Bartonella, and let's say it's 80% better. You should have less fear. But a lot of times that feedback loop doesn't break.
Right.
Methylene blue can break it.
Yeah.
Which is great.
The thing about methylene blue, when I first started using it, the low doses, as you know, can actually help the mitochondria, the parts of the cells that make energy to work
Yes.
better. Even at like ridiculously low doses of like 8 milligrams, right? They're using it in
I do 5
Alzheimer's.
milligrams a day. Yeah.
Right. They're using it in Alzheimer's in studies now for the mitochondrial hypothesis that it's not all based on amyloid. It's based on mitochondria and the nerve cells in the brain that are just not working. So it's a really interesting drug. But the interesting part about the fear response that you were talking about getting better, for people listening, the reason you can have hope is up until 10 years ago, we didn't know that Lyme and Bartonella were what are called biofilm persister bacteria. What that means is we didn't know, for example, you go to the dentist to get the plaque taken off of your teeth, that's a biofilm. If you don't get to it, there's Porphyromonas gingivalis. They've shown Porphyromonas goes up into the brain. It's one of the things associated with Alzheimer's disease, right? So you need to open up the biofilms. And we've had patients, we open up the biofilms, they start herxing because your immune system all of a sudden is recognizing the bugs. And in the dapsone protocol, we use 4 biofilm agents, some of which including biocidin, cinnamon clove oregano oil, stevia from Nutrimetics, which was published by Eva Shapi, and peppermint oil, because it lowers the MIC, the amount of drugs you need to get some of these resistant bacteria. And when Tom was discussing putting drugs together, just know the rule of thumb with some of these infections: 4 drugs works better than 3, 3 works better than 2, 2 works better than 1. So for those of you starting off, you're not going to start that way, but the science actually says in culture and in the studies we published, the more intracellular drugs with biofilm agents, the better it works. And right now, the dapsone protocol is a 9-week oral generic protocol. You wait 2 months. If you have BART, we do 2-week pulses. It's 6 days of high dose dapsone. You're never doing long-term dapsone after that. And on the average, it's taking at least 4 pulses to knock BART out. The when it doesn't work, by the way, in 4 pulses, it's almost always long COVID and mycotoxins are usually the things on the top of the list that are interfering at this point. And also for testing, just know, for those of you not sure if you have BART, the Bartonella immunoblot from IGeneX, their IgM, IgG, and BART fish, fabulous, because again, it's picking up multiple species. I can't do Galaxy in New York, but again, their ddPCR, their direct droplet PCR, excellent for looking at these different ones. But you've got to go way beyond antibodies, because their immunoblot, and I'm sure, Tom, you're finding also T-Labs, their Bartonella fish, I'm finding their BART fish, just like IGeneX's BART fish, is picking it up in patients where the other testing is just not picking it up.
Yeah, I mean, I think again, there's a few really trusted labs. And I tell people all the time, and we worked with IGeneX to create the 4 immunoblot discount panel. So you can get all 4 immunoblots for like, half price, which is great. So if any doctors need to know the trick to that, reach out to Rich or I. We can get you I have a custom order form I send to people because it's like, it's not on the official list, but it's an official test. But because it's expensive, but I think, you can invest the money now and you can invest the time to do all the things you can do yourself, and you work with your physician and follow the protocol rather than getting in the support group and going on Google and like net surfing and trying to get a better deal and trying to like come up with a better protocol. There's probably hard to come up with a better protocol than physicians who've been doing this for 15 or 30 years. Bring your ideas to them, but work with them. And I've definitely seen that. And one of the tricks that you reminded me of is you're talking about P. gingivalis and how it messes with the mouth. And I think that, when we look at strep and how it causes autoimmune encephalitis, and in children, we call that PANS. A lot of it is probably recurrent infection in the mouth and the nose. And then you'll get mycotoxin illness. We've got colonization in the nose and the gut. And then we have SIBO. Oh, why do I have SIBO? Well, it could be your crappy diet. It could be that you have to be on antibiotics for a period of time. And don't think that botanicals don't mess with your gut. It might be less than antibiotics, but they can certainly change it as well. One of the tricks I've used for people with brain fog, for kids who get recurrent strep and we want to protect them in school, and just people who want to live longer, or people who have gone through SIBO treatments and haven't really been highly effective, or they're effective, but then they relapse constantly, is to remember that there's about 100 million organisms in 1 milliliter of saliva, and we swallow about 1,000 milliliters of saliva or a liter of saliva a day. So that's like 100 billion organisms you're swallowing. I use Biocidin's dental side and toothpaste in their other parts of their dental program to work on the oral biofilms, and they've done studies that show the optimization of the oral microbiome so that, one, we're not having as much P. gingivalis that can go into our brain and lead to early cognitive decline, which everybody, if you have any poor oral health, that's going to be a problem. But now you're also seeding your gut with a more optimal bacterial balance. And if I do that, in addition to all the proper probiotics that we're putting people on in these protocols, then we can have a better immune response in our gut and less likelihood of dysbiosis. And so it's like you're brushing your teeth 2-3 times a day anyway, or if you're not, you should be. Now we have a way to use those products to actually have health optimization way beyond just our mouth. And a lot of the other, the commercial toothpaste, most are crap and very acidic. And a lot of the natural toothpaste are acidic. So I'm just like, why don't we go to something where we've studied it to show optimal microbiome balance, as well as remineralization of teeth and natural whitening, because everybody kind of likes that. But the most important thing is it's healthy for your brain, it's healthy for your gut. And if it's healthy for those, it's healthy for your immune system. So it's just like one of these little tricks that I learned over the years, to help people who are getting stuck in certain ways. So wanted to make sure we shared that as well.
Yeah, and regarding the microbiome, we use 4 different probiotics twice a day. It's over 500 billion twice a day. We use Theralac from Master Supplements, Orthobiotic, Saccharomyces boulardii. We haven't seen a case of C. diff in years. And the Probiomax 350 billion, which is acid resistant, that gets into the lower gut. And I tell people, a little bit of organic flaxseed, organic black seed, we're using these fibers because fiber ultimately is helping butyrate in your gut, and you've got the good probiotics. So we're finding that the microbiome of the gut is actually staying in good shape as long as we're keeping down the carbs. You're not doing, getting candida overgrowth, and you're taking these probiotics. So, Tom, quick question. We're getting close to the end. You and I could be doing this for hours, clearly. How do people get in touch with you? Tell people the best way to get in touch with you. Tell them a little bit about your training course that you have for docs, in case all doctors out there are listening and want to also learn more about your course.
Yeah, thank you so much. Our training course is called the Lyme Disease Practitioner Certification and Mentorship Program. And it's meant to be a place where we do mentorship primarily. I do teach all the concepts, reinforce it, recommend everyone go become an ILADS member, do the ILADS trainings, definitely do your trainings. And it's a place where try to help people on an ongoing basis really get to the place where the rubber meets the road and help give them real-time feedback when they're trying to apply like dapsone or double or quadrose dapsone and stuff like that. So that's at lymepractitionercertification.com. It's an amazing community, and it's just a great place for us to support each other and get real-time feedback. And then also our medical practice is originsofhealth.com. So certainly see patients and always happy to help people who need it. On YouTube, we're Origins of Health, Instagram, Dr. Tom Moorcroft. And we're just really trying to put out a lot of information to help, just like you are. I know we both have Substacks and newsletters. We're just trying to get the information out there to help people. And, also happy to share with you guys for your audience, our Stress Less, Live More ebook. It's really about energizing your life with purpose, passion, and balance. And I really tried to put together as a thank you to everyone listening, a book that really, and an experience that goes through what I learned from healing from chronic Lyme Babesia. And thanks to you pointing this out to me when I rotated with you, turns out there was also some heavy metal toxicity. But there was about 70% of my healing really came through what I did personally. And that, and how I took back control of my life. And I did what the doctors said, but I also was doing these daily practices, but I wanted to make it easy because I was in medical school and residency. I didn't have time for all this stuff. And most people are trying really hard, but they don't want to, they don't have the time to make their whole life about being sick. Because if you make your whole life about being sick, then you're going to stay sick for a really long time. So it's a balance of how to put that into your life. And so I really wanted to share that with people as well. So happy to support all the docs, happy to support all the patients. That's what we're here for. And I feel like we need a village of people to do this, and just so everyone knows, like Rich's book says, you can get better. And that's what we're all here to help you do. And Rich, I just want to say thanks for the opportunity to chat, and thanks for all you've done for myself, my family, personally. So much love to you and your wife, Lee, but also professionally. If ILADS is 25 years as of, their fall 24 conference. And I've been a member for 21 of those. And if it wasn't for those first 4 years before I came around there, I probably wouldn't be standing here, if alive at all, because of the chronic Lyme and Babesia and heavy metal toxicity. And so you've personally changed my entire life, and I know you've changed the lives of so many people. So just an honor to be able to be here.
You couldn't be a
and
nicer
part of it
guy,
with you.
Tom, who's in medicine to do it for you and your wife and Talia. You're just great people. So it's been my pleasure to know you guys personally also. So yeah. So for everybody, we've been discussing today with Dr. Tom Moorcroft, healing some of the co-infections that are very, very common, which is specifically Babesia and Bartonella. So thank you all for tuning in. My name is Dr. Richard Horowitz. You've been listening to the Healing Lyme Summit 2.0. I'm Dr. Richard Horowitz, and again, we'll be tuning in with a new episode soon. Thank you, Tom, for taking the time today. It was a great talk, and I look forward to seeing you all very soon.